I'm going to keep our intro short this morning. We have Dr. Jacques and Dr. Bennett to present, both members of ASOG and active in our family planning group. They've been really leaders for us, both locally and in our department and also in the state. Both also work at Planned Parenthood, and we're really excited to hear their talk this morning.
Okay, so we are going to talk about the diagnosis and management of non-viable early pregnancy today.
Also, a quick shout out to Molly Lepic for helping me come up with the clever title.
So early pregnancy loss affects 15% of clinically recognized pregnancies, and 25% of women will experience an early pregnancy loss. The diagnosis and management of early pregnancy loss has markedly changed over the last few decades. Historically, it was almost universally diagnosed or managed surgically, and the diagnosis was rather haphazard with no set standard guidelines for the diagnosis. In recent years, better scientific evidence has improved treatment options and has resulted in more precise diagnosis. And so today we're going to review this progress. I am going to start by talking about the ultrasound diagnosis of early pregnancy loss. So just to review, usually pregnancy develops very, very predictably. At 4.5 weeks, you see a gestational sac in the uterus. At 5 weeks, you see a yolk sac. And at 5.5 to 6 weeks, you see a crown rumpling. The crown rumpling almost always has cardiac activity as soon as you can see it. If there are variations from this standard, then there is concern for early pregnancy loss. However, we now know, because of a body of evidence, that it doesn't always mean that you have an early pregnancy loss. There was a diagnostic criteria published in 2013 from the Society of Radiologists in Ultrasound that updated our previously haphazard criteria for diagnosing non-viable pregnancy. This criteria came out of a body of work that had also informed the changing criteria in Canada, in the UK, in Australia, and New Zealand. And since this diagnostic criteria was published, ACOG has embraced it, albeit with some reservations. And those reservations are because the goal of this paper states that it is to achieve criteria that arrive at 100% positive predictive value and 100% specificity for non-viable pregnancy. And their reasoning was that a false positive diagnosis could interrupt a potentially viable pregnancy, whereas a false negative diagnosis only resulted in a few days of waiting to obtain that diagnosis. So we don't know necessarily that that is true, because we haven't had studies that have specifically looked at what that waiting period entails and whether there is risk that occurs during that waiting period. And also, this criteria becomes very restrictive. The majority of non-viable pregnancies will have to wait in order to be able to be diagnosed. And this may not be consistent with the goals of every patient. But I am going to review this criteria and we'll examine that. So one of the first things that they talk about in this paper is the discriminatory level. Historically, the discriminatory level was set at about 6,500 when we just had transabdominal ultrasounds. And that's the level where you should definitely see an intrauterine structure if you have a pregnancy that's going to be an intrauterine pregnancy. And then once transvaginal ultrasound became available, the discriminatory zone was dropped to about 1,500. 1,500 ultimately would prove to be a little too low to definitely diagnose every pregnancy that would ultimately be intrauterine and viable. So over time, the discriminatory zone was raised, but not specifically raised. In this article, they chose 3,000 as the discriminatory zone, but do mention that at the level of 3,000, there still is a possibility of a viable pregnancy being in the uterus, but it's probably on the order of about 0.5%. Subsequent to this paper, an article came out of North Carolina that showed that their assertion was likely right. So they looked at 650 patients with vaginal bleeding who had an ultrasound and a beta HCG within 6 hours of each other. And the highest threshold level that they found for finding a structure within the uterus, a gestational sac, was 2,363. So no ultimately viable pregnancies saw an intrauterine gestational sac higher than that level. Then they used math to look at how would we take that number and get to that over 99% specificity that the Society of Radiologists and Ultrasound desired. And they came up with a number of 3,510 as the threshold level where you should at least see a gestational sac in the uterus in an ultimately viable pregnancy. However, they do mention that this confidence interval is very broad, between 2,000 and 8,000. And so really going along with the SRU guidance, we should be looking at serial HCGs to make the diagnosis of a non-intrauterine or a non-viable pregnancy. So the rest of the guidelines looked at what structures you see, when you see them, and when you can diagnose a non-viable pregnancy. The orange arrows indicate the parts of the SRU guidelines that were actually based on expert opinion and not data. And I'm going to review the guidelines, how they came up with those, and then what's come out after this to give us more guidance in these gray areas that weren't really based on science. I really want to highlight that the crown rump length of less than 7 millimeters, to diagnose it as non-viable was essentially in a footnote that gave a vague recommendation to do a scan in 7 to 10 days. Thankfully, somebody looked at this and we can move on from that. Okay, so if you have an empty sac, it can be physiologic, but if the sac is large, it starts to be more and more likely that that's going to be a non-viable pregnancy. So about 40% in a large study of over 1,000 women, about 40% of empty sacs were ultimately deemed to be viable pregnancies. So 60% non-viable, which isn't too bad. Historically, the cutoff had been about 16 millimeters to 18 millimeters to diagnose a non-viable pregnancy. And what they found in this large study of over 1,000 women was that would give us a rate of about 4.4% false positive diagnosis of non-viability. They found that no viable pregnancies were seen after a mean sac diameter of 21 millimeters. And then an additional study looked at the inter-observer variability between ultrasonographers and found that that variability was 19% in obtaining a mean sac diameter. So that's where they came up with the 25 millimeter mean sac diameter as a threshold to diagnose non-viable pregnancies. So this is going to be very specific, but it's also going to mean that 98.8% of empty sacs will not be diagnosed as non-viable on the first scan. They will have to wait 14 days in order to ultimately get that diagnosis. So in pregnancies with a sac and a yolk sac, this is the kind of most promising outcome for viability that we see. 63% of these pregnancies are going to be viable on repeat ultrasound. In that large study that I referenced, I have the specificity and sensitivity table up here. You can see that mean sac diameter greater than 21 was specific for a non-viable pregnancy. However, because of the high rate of viability, they did not recommend using mean sac diameter as the cutoff to determine non-viability in these sacs with yolk sacs. Instead, they recommended a repeat scan in 11 days. A follow-up study looking at this phenomenon did show a single viable pregnancy with a yolk sac at 25.7 millimeters. And so the 11-day waiting period, is supported by this follow-up data. But what about crown rump length? This is the worst prognosis. So if you see a crown rump length within a gestational sac and you don't see cardiac activity, most likely this is going to be a non-viable pregnancy. Historically, the level was set at 5 millimeters. This data table is from a study looking at 21,000 first trimester pregnancies, and it only looked at whether or not they eventually had a heartbeat. It didn't look at whether they were ultimately viable and resulted in a live birth. So they found that the 5 millimeter threshold was sensitive to determine non-viability, with 99% of non-viable pregnancies having a crown rump length less than 5 millimeters. But they found that about 6 pregnancies would have obtained a false positive diagnosis of non-viability with using the 5 millimeter threshold. So very few, but some. So based on this and an additional study that showed no viable pregnancies with a crown rump length greater than 5.3 millimeters, the SRU created the guidelines using a 15% inter-observer variability of 7 millimeters as the cutoff. A follow-up study confirmed that this is an accurate threshold with no viable pregnancies in the follow-up study greater than 6.2 millimeters. So what about that time criterion? So the SRU guidelines recommend that you should see an embryo with cardiac activity by 14 days after initial ultrasound of an empty sac to predict viability, and by 11 days after an ultrasound with a gestational sac. As I said, this recommendation was not based on any prospective trials looking at timeframes, mostly because it was really hard to follow people over time and determine, whether their pregnancies were viable or non-viable, because people want answers. But this British group looked at these patients over a period of about a month and found that in patients with an empty sac, the positive predictive value of seeing a crown rump length with cardiac activity at 14 days had a positive predictive value of 98.6 and a specificity of 99.5. They found one single pregnancy that had a gestational sac of 3 millimeters on the first scan, and 14 days later had quadrupled in size, but did not yet have a crown rump length or cardiac activity, and ultimately went on to be viable. The 11-day criteria for yolk sac was found to be 100% specific with 100% positive predictive value. So based on this study, looking at these patients later on, they compared the mean sac diameters with or without yolk sac to come up with a new threshold. And what they found was mean sac diameter is actually the thing that's most predictive, not the presence or absence of yolk sac. And so a mean sac diameter that is very small has a much higher chance of being viable and should be watched for a longer period of time. Whereas a mean sac diameter that's large is more likely to be a non-viable pregnancy, and you need less time to determine the viability. So their recommendation was that if the mean sac diameter was less than 12 millimeters and it hadn't doubled after 14 days, you could diagnose that pregnancy as non-viable with 100% positive predictive value. Whereas if it's greater than 12 millimeters, you can scan them in 7 days and you should see an embryo with cardiac activity by that point and can diagnose as non-viable. So then they also looked at the crown rump length, which, as I said before, just gave vague recommendations to scan in 7 to 10 days. And they found that the absence of cardiac activity, regardless of the duration of time to scan, 3 days, 5 days, 7 days, 10 days, 14 days, you were able to determine viability on the repeat scan. So 7 days is definitely reasonable. but they were able to determine viability at the 3-day scan in all eventually viable pregnancies. So this is an area where perhaps we could actually get a shorter duration of time and make patients wait less. Finally, this group did look at one other criteria that we all feel clinically is really relevant, but most of these studies didn't look at, and that's gestational age. If a patient is more pregnant and they have, a small sac with nothing in it, or a crown rump leak with no cardiac activity, they're highly likely to have a non-viable pregnancy. Because these studies were done in the UK, they don't do standard dating scans. The majority of these patients that were further along would come for their nuchal scan and then be found to have a non-viable pregnancy. So they had cutoffs. The cutoff that they set was a gestational age of 70 days, which is 10 weeks and pretty far along. But they found, if you look at these scatter plots, blue is non-viable, gold is viable. Gestational age is along the bottom, and the crown rump link and mean sac diameter is along the sides. If you look up in the far upper outer quadrant, you'll see those are all blue. So a sac that's above 18 millimeters and beyond 70 days of gestation confers 100% positive predictive value for non-viability, as well as a crown rump length greater than 3 millimeters. Okay, and now I'm going to let Laura dig into HCGs.
All right. So data also shows that people start to drift off after about 10 minutes of a talk. So we decided to switch off back and forth to wake you back up. So the next bit of the talk is going to be a little bit dense because it's about serial HCGs. So if you want to grab a cup of coffee and refill that, if you're at home, please do. Also, some people are taking this opportunity here. So Dr. Bennett just talked to you about how to manage ultrasound findings in early pregnancy. But what do we do if we don't see an intrauterine gestation on ultrasound? Most of us and many clinicians will typically use serial HCG or human chorionic gonadotropin levels to diagnose and manage what is now a pregnancy of unknown location, or heretofore to be called PUL. The diagnosis of PUL should be transient, and all of us should make efforts as best we can to determine the location of the pregnancy if possible. So for this next bit of the talk, we're going to go through the evidence that can help us answer the following common clinical questions. All right, this isn't animated. So if I down, yes, good. Okay. And also thank you to Cassidy for animating the slides because I couldn't figure it out. What is an expected rise in HCG in early pregnancy? If the HCG rise is slower than what's expected, does that mean that the pregnancy isn't viable? What if the HCG is not rising, but rather declining? Does that mean the pregnancy isn't viable? And how can we distinguish ectopic pregnancy from miscarriage in this scenario? When or should we repeat an ultrasound if we have suboptimally rising or declining HCGs and no intrauterine gestation on the initial ultrasound? If we have a suspicious non-viable ultrasound, like what Dr. Bennett just talked about with the SRU criteria, can we use serial HCGs to get a diagnosis more quickly? When should we offer intervention in PUL with suboptimal HCG rise or decline? When is it safe to stop checking HCGs in a PUL? Do we have to follow every pregnancy until less than 5 and 0? So, as with anything, before we can talk about abnormal, we have to know what's normal. What is the expected rise of HCG in early pregnancy? HCG is first detectable in the serum 8 days after ovulation, much to many of our chagrin. And that's likely the time of implantation. And then the rate of HCG rise correlates with the doubling time of trophoblastic or pregnancy tissue cell number. Levels will naturally increase during a viable pregnancy until about 10 weeks when they'll hit 100,000. And then they naturally start to decrease until they reach 20,000, which is where they'll sit for the rest of the pregnancy. Numerous studies have looked at what the rise in HCG is in both normal and abnormal pregnancies. And though there's consensus that with a normal pregnancy, the HCG rises at a steep decline or a steep incline, and that looks very different than the slow rise or plateau that you see with miscarriage or ectopic pregnancy, there actually is a lot of disagreement about the rate of increase and the type of curve that can best describe the rise of a normal viable pregnancy. Until 2004, we relied on a study from 1981 of 20 patients. And they had reported that the lower limit of the curve was 66% rise over 48 hours. So this just became the threshold for which we determined a likely non-viable pregnancy for many, many years. Clinicians used a 66% rise over 48 hours as the diagnostic criteria. If it was less than that, it was non-viable. And at that point, most people just got a D&C. However, there were several obvious pitfalls to this study, which many of us can imagine right now. First, the sample size was 20 people. Additionally, the people in this study were not necessarily people that were symptomatic. So they may not have had bleeding or pain. So they may not be representative of the patients we're clinically interested in. And they used an 85% confidence interval, which, as a quick refresher, the confidence interval is the probability that a parameter is going to fall within a set of values. And 85% is not a high degree of certainty. So 20 years later, long after clinicians were routinely using a 66% rise in clinical practice, some researchers at Penn decided that they wanted to look into this data better so that they could more accurately diagnose viable, non-viable pregnancy and ectopic pregnancies. And they did what, as a researcher, this is like my dream. They amassed this massive database over 17 years from 1990 to 2007, and they created this predictors of ectopic pregnancy study. And then they took this database and they did every calculation you could ever imagine about what HCG will do or not do during every type of pregnancy. And then they published it in the Green Journal, in the Gray Journal, in JAMA, and the New England Journal of Medicine for 20 years. It is an incredible study, and it basically forms the basis of everything that we now know about HCG trends in early pregnancy. So we're going to go through a few of these studies. Saddle up. So the first thing we wanted to talk about was, what is the expected rise in early pregnancy? So this group, which was led by Dr. Kurt Barnhart, respect, an REI at Penn, he wanted to know how they could optimally diagnose and manage patients with PUL. Being an REI, that makes a lot of sense. That's critically important to their field. So they conducted numerous retrospective cohort studies of this large database. And to figure out what they wanted to know, what is the rise in early pregnancy, they took patients who were symptomatic, so they had some bleeding or they had some pain. They did not have an intrauterine gestation diagnosed on their initial ultrasound. And then people that had had serial HCGs. At the time, Penn was routinely monitoring everybody every 48 hours with HCGs, so they had a ton of data. They also then looked at people that were found to have a viable intrauterine pregnancy ultimately. So that's who they included. Notably, their definition of viable intrauterine pregnancy was just ultimately a gestational sac with a yolk sac or fetal pole on ultrasound. And then they looked at the rate of increase in those patients. And they found that the median increase was 124% over 48 hours. But more clinically important, they looked at what the slowest rise was that ultimately resulted in a normal viable pregnancy. So the level with which 99% of people will ultimately have a viable pregnancy. And that rise was 53% over 2 days. They didn't see anybody who had a slower rise that ultimately had an intrauterine pregnancy diagnosed on follow-up scan. So their conclusion was that this is the new threshold. It's not 66%, it's 53%. That strongly suggests non-viable pregnancy. And that's a point where you should consider intervention to figure out, is this ectopic or is this a failed intrauterine pregnancy? Over time, they decided that, you know what, we have all of this data. We should better determine, we can be more accurate than this. And so they started looking at different criteria. They hypothesized that based on what the initial HCG level was, people would have different slopes of rise in their pregnancies. And so they then looked at the initial HCG rise to try and determine again, what the slowest rate of rise would be that would ultimately lead to an intrauterine pregnancy being found on ultrasound. And they found that the higher the starting HCG, the slower the slope of the curve. So the box that you see here on the right gives the HCG ranges that they looked at. And for the highest HCG level, which was greater than 3,000, which they selected because of the, oh, I'm on the wrong slide. Thank you. Bless your heart. Okay, so I get talking, as many of you know. So get excited. So the 3,000 was the commonly used viability threshold where you expect to see something on ultrasound. So that's why they hit that as the upper limit. And they found that the slowest rate of rise was 33% over 48 hours. So 99+% of pregnancies are going to have a rise faster than 33% over 48 hours if they start with an HCG of 3,000. And so they didn't say you should like throw out the 53%, throw out the baby with the bathwater, but they did say that physicians should start to tailor how they diagnose early pregnancy based on what the starting HCG was. So look at that, then look at the doubling time, and then you can use these criteria here in the box to determine with 99% confidence interval accuracy that yes, that is a non-viable pregnancy. So we just discussed the expected rise of HCG in early pregnancy. The next question is, what if the HCG isn't rising, but what if it's declining? And Eliza and I actually had like a deep lit search into that. Where like everybody assumes if an HCG is declining, it's non-viable. And we're like, is there literature that says this? No, this is just assumed. So there we have it. We are assuming that when an HCG is declining, the pregnancy is non-viable. So then if you assume that, the question at this point becomes, is it a non-viable intrauterine pregnancy or is it a more worrisome ectopic pregnancy? And you know who decided to figure out how we can determine this? Yes, these researchers at Penn. So again, unlike the rising HCG values that we just discussed, the goal when the HCG value is declining is to figure out whether it's a non-viable intrauterine or an ectopic pregnancy so that you can make the correct management decisions for the patients. And they took their same fantastic database and they looked at people that were symptomatic in early pregnancy, that didn't have an ultrasound diagnosis of an intrauterine pregnancy. And then they took people, unlike people that ultimately had a viable IUP on ultrasound, their new endpoint was people that had a proven miscarriage, so a proven intrauterine pregnancy that failed. And then they looked at what the slopes of those curves were. And they had 710 patients that they were able to include in this study. They found, similar to the rising HCGs, that the slope of the curve depended on how high the HCG was when you started. The higher HCGs decline more quickly than the lower HCGs. And then they looked at what's clinically relevant, which is what is the slowest rate of decline that ultimately ended up in miscarriage. And that was 21% over 4 days and 60% over 7 days. So their conclusion from this data, and this is a 95% confidence interval, they use a higher confidence interval for the intrauterine because they're just like the ultrasound people. They thought that the worst thing somebody could do was to interrupt a viable pregnancy. So they wanted like the most certainty for that. If somebody treated a ectopic, like a miscarriage or vice versa, they thought that was like still not a great error, but a lower category error. So they set their confidence interval a little lower. And they concluded that this decline of less than 21% over 48 hours or less than 60% over 7 days, this meant with good certainty that this was a pregnancy at risk for ectopic pregnancy. And that is the point that intervention should be put forward to either figure out which one it is with a diagnostic DNC or to treat empirically with methotrexate. They did actually do a really great randomized control trial, which I'm not going to talk about today because Eliza and I both agreed we don't have time, called Act or Not, that Dr. Bizzuto collected patients for in the middle of the night at Penn that you should read, that answers which one of those things is better. Anyway, so what about scenarios that don't fit into this situation? When does repeating an ultrasound become useful in patients with persistent PUL? Don't have a lot of data, but we do have one study that I think is pretty cool. So in 2007, a group, not the Penn group, for the first and only time today, conducted a study of their EPAC patients. So these people were like early adopters of early pregnancy assessment clinic, or EPAC. And they wanted to know, do we need to scan everybody at their first visit? What happens when we scan people? So they had over 5,000 patients, and they found that on the initial ultrasound in this early pregnancy assessment clinic, so patients who were symptomatic in early pregnancy, 91% were able to have the location of their pregnancy diagnosed on that first scan. And the vast majority of these, about 90%, were intrauterine pregnancies. A little over 1% were diagnosed on that first scan with a pregnancy. And that left about 9% who were classified initially as a pregnancy of unknown location. That was about 456 patients. Ultimately, 7%, or 31 of those 456, were found to have an ectopic pregnancy based on villi at the time of laparoscopy. So then they looked at those 31 patients that were verified to have an ectopic pregnancy, and 93.5%, or 29 of them, had findings that were suspicious or diagnostic for an ectopic pregnancy on a follow-up ultrasound. And the median time between scans was about 7 days. So they concluded that if you're still following along HCGs a week later and you don't know, is it in the uterus, is it ectopic, an ultrasound can be very helpful. And if you have an ectopic, 93% of the time, you're going to see signs of that on that ultrasound. All right, so we've answered our first 4 questions, and all of these covered HCG monitoring in pregnancy of unknown location. The next question is one that we come across quite a bit, I think, which is, okay, you got one of these ultrasounds that Dr. Bennett just talked about that have like a crown rump length with no cardiac activity. Do you have to wait 7 days? Like, we know this is a non-viable pregnancy. Is there anything that we can do to expedite diagnosis? Can we check serial HCGs? Is that enough? Is that going to tell us, okay, in combination with this likely or risk for non-viable ultrasound, if we do HCGs, is there anything that we can learn from that that can give the poor patient some information sooner? Don't have a lot of data, so it's important to keep that in mind as we discuss this, but there is one really well done study from researchers in France. And they conducted a prospective study of patients, a cohort study of patients who met the SRU ultrasound criteria for uncertain viability. And then they checked serum HCG levels the day of their ultrasound and every 48 hours. And then they looked at ultimately what happened to that pregnancy and what was the rise or decline of HCGs. And they found that when the HCG increase was less than 11% over 48 hours, this was 100% specific for ultimately finding a non-viable pregnancy on that follow-up ultrasound. And that affected about a quarter of patients. About a quarter of patients could have had a diagnosis 48 hours instead of 7, 11, or 14 days later. Conversely, if the HCG rose greater than 75% over 48 hours, then that was also 100% specific for a viable pregnancy to be found on their follow-up scan. And that affected about 17% of patients. So overall, serial HCGs were able to give people with 100% specificity information about their pregnancy, either viable or non-viable, within 48 hours for 41% of patients. Again, it's important to recognize that this is one study and we don't know about the reproducibility of this data in other cohorts, but it's very interesting. So we've gone over the rates of HCG rise and the rates of decline and what that means. The next thing we need to think about is, okay, once we've sort of been watching these HCGs, when should we intervene? And the previous data showed that offering intervention if the HCG rises less than 33% over 48 hours or declines slower than 21% over 48 hours, that could be a good time to intervene. So our friends at Penn said, okay, if we take these recommendations that we created and we apply them to a cohort of patients in real life, what happens? What are there, again, their primary goal was, are there pregnancies that we will interrupt if we were to apply our curves to these patients that ultimately become viable? And so they took another large cohort of patients from a different time frame from their massive Nonviable data set, and they applied various different rates of curve. First, they looked at that first study that they did, which was the rise of HCG in what is known to be a viable pregnancy. And then they put different confidence intervals to that. And then they applied not just that, but then they applied their other curve, which was the one that had known miscarriage at the end. And they applied different confidence intervals to that. Again, they used tighter confidence intervals for the intrauterine viable pregnancy because their primary error they wanted to avoid was intervention in what would become a viable pregnancy. They used a lower confidence interval for the miscarriage data because they thought that mismanaging an ectopic versus a miscarriage was less of an error. So they ended up discovering that with a 99.9% confidence interval for rise, which using all comers of HCG ended up to be a 35% rise over 48 hours, and a 90% confidence interval for miscarriage or decline, they found that the number of pregnancies, if you applied these rules that they had previously given, that you would interrupt would be 4.6%. So 4% of pregnancies, if you applied their data, would ultimately have gone on to be viable intrauterine pregnancies. And again, the definition of that was just seeing a gestational sac with a yolk sac or fetal pole on ultrasound. So they thought, well, that maybe isn't good enough. So then they looked at, what if we did a third HCG value? And at Penn, your Penn people must know this, they must have checked everybody's HCGs every 48 hours forever. So they had a huge trove of people that they'd also checked a third HCG for 48 hours later. And they found that that did improve the false positive rate, and it cut it by half. So if you use 3 values every 48 hours that are rising by less than 33% or declining less than 21%, you will still interrupt, though, 2.2% of pregnancies that ultimately go on to be viable, but they determined that this was, the absolute best that you can do. It's a 99.9% confidence interval. So that was the recommendation. You should consider 3 instead of 2 values, and you want that 53% rise that they had talked about in their very first 2004 study out the window. It was too loosey-goosey. That wasn't in my original planned words. Okay, when is it safe to stop checking HCGs in a pregnancy of unknown location? Do we have to follow them until less than 5? How many of us are like, God, this lady's still coming back, or this patient is still coming back for HCGs? Poor thing. So our same trends from Penn have also looked into this. When can you stop checking HCGs in somebody who has a pregnancy of unknown location? So they conducted another retrospective cohort study from their database, and they included, again, patients with PUL that had serial declining betas, and they were measured every 48 hours because that's what they do there. And then they looked at people that had a documented date of eventual definitive diagnosis of either miscarriage or ectopic pregnancy. So they could prove at the end that they'd either had an intrauterine pregnancy that failed or an ectopic pregnancy. And they wanted to see if the slope of decline for miscarriage looked different from the slope of decline for ectopic pregnancy, so that if your primary goal was ruling out ectopic pregnancy in these patients, is there a point where you can say, okay, we have definitively ruled out ectopic pregnancy. We do not need to keep testing this patient because the patient doesn't have signs or symptoms of retained products. And they found that yes, you can. If the HCG falls by greater than 85% in 4 days or greater than 95% in 7 days, ectopic pregnancy was 100% ruled out. Pregnancies that had that curve never went on to be an ectopic pregnancy. They were always a failed intrauterine pregnancy. And they had a 95% confidence interval with a pretty tight confidence interval, 96.8 to 100. And so their recommendation from this was that if you're monitoring these falling HCGs, and this is clinically most useful in patients that come into the ER and they're having bleeding and they just have never managed to get their first scan, and based on what they're telling you, they had a miscarriage, There's nothing in the uterus, like this is done. But because you never knew, was it intrauterine? Was it ectopic? You kind of have to keep following these people. So this helps in this subset of patients. You can check them again in 4 days. And if it has fallen from that visit in the ER or your clinic or wherever by 85%, then you can definitively say they do not have an ectopic pregnancy. This was a miscarriage. And then you can decide how you want to follow that patient. You can decide if you want to keep checking HCGs because you're worried based on their bleeding pattern that they might have retained products, or more likely you can just stop checking them. All right, that's it. This is the summary of the takeaways. HCGs that rise more than 33% over 3 checks every 48 hours, very likely to be non-viable, reasonable to intervene. HCGs that decline less than 21% over 48 hours are an ectopic pregnancy until proven otherwise. Intervention, either diagnostic DNC or empiric methotrexate, read the ACT or NOT trial, should be offered. If the HCG declines 85% in 4 days or 95% in 7 days, ectopic is ruled out. You could consider stopping checking them. With PUL, if you don't have a diagnosis in 7 days, consider doing an ultrasound. It's very likely to be helpful. And again, if you're in this situation where you have an ultrasound that SRU says is suspicious for non-viable, you could clinically consider, through shared decision-making with your patient, checking HCGs. And if the rise is less than 11% over 48 hours, very likely non-viable. All right.
Okay, we are going to briefly discuss management of early pregnancy loss. Thankfully, not much has changed here. So expectant management of EPL used to be discouraged because they believed historically that there was a high rate of infection, and so surgical management was optimal. But over time, that belief was dispelled and expectant management became more popular. So then the question was asked, well, if you just let people wait and see when their pregnancy comes out, how long does it take? And how successful is it? Large study from the UK, because the UK people have these easy early pregnancy units and have huge populations of patients that they can study, showed that expectant management was popular. So they had 1,000 patients, 600 of which qualified for expectant management. They offered it to all the patients, and 70% of them desired expectant management. They prospectively followed all these people to see what happened with their pregnancies. They offered all of these patients surgical intervention at any point that they desired it. They recommended surgical intervention at 4 weeks, but allowed patients to continue expectant management beyond that. And what they found was that a total of 81% of patients had a successful spontaneous expulsion of the pregnancy. It was much more likely in patients that had an incomplete miscarriage, with 91% of them eventually expelling all pregnancy tissue, whereas anembryonic and missed abortions had lower rates of expulsion. The majority of patients will expel the pregnancy by 14 days, 70% of people. The duration of time does increase the number of patients that will expel the pregnancy, but it's only marginally better after that 14 days. Only 3% of patients desired expectant management beyond 4 weeks in this group of patients. There was another study out of Sweden that looked at whether bleeding conferred a higher likelihood of success, and it did not. So it was just looking not at incomplete, because they'll all be bleeding, but at missed and anembryonic pregnancies presenting with bleeding, and found that they had a similar completion rate. Finally, there was an additional study based on this large group of patients that had expectant management, and found that the risk of infection or hemorrhage at 2 weeks was only had an incidence of 2.5%, so acceptably low complication rate. There's been a Cochrane review from 2011 that looked at early pregnancy studies that compared early pregnancy loss to surgical management. And basically, surgical management is more effective at getting a pregnancy out of the uterus, unsurprisingly. And expectant management results in a longer duration of bleeding and a higher risk of blood transfusion. However, it's only a 1.4% chance of blood transfusion, and the confidence interval for this risk is quite broad. The benefits of expectant management is lower cost. So there was a British study looking at the cost between expectant management and surgical management and found that it was about 500 pounds less for patients that had expectant management. There were no differences in psychological outcomes, and pain differences were very mixed, and it really depends on what kind of pain management people get at surgical management when you're comparing the two. Okay, so medical management is the place where we've had the most changes. So medical management of early pregnancy loss has increased in popularity since medication abortion became available, and people realized we can use misoprostol and then subsequently mifepristone and misoprostol to treat early pregnancy loss. So a Cochrane review in 2021 looked at the three methods, medical, surgical, and expectant, and compared the three of them and found that medical management was less effective than surgical management, but more effective than expectant management, had a lower risk of unplanned surgery than expectant management, and a lower risk of infection compared to surgical management. Medical management does have a higher risk of GI side effects, mostly because misoprostol is notorious for doing that. So the real big thing that's changed in the last few years is that there have been 3 randomized controlled trials comparing mifepristone plus misoprostol to misoprostol alone for the medical management of miscarriage. And we can conclusively say, based on these 3 trials, that mifepristone plus misoprostol is superior to meso alone. So in the setting where you have access to mifepristone, that should be administered in order to affect a higher success rate of medical management of miscarriage. Most studies showed about an 80% rate, but there's some heterogeneity here because the different studies use different days and different endpoints to diagnose success. But basically at around day 4 to day 14, 80% of people will have expelled the pregnancy tissue. Mifepristone, 200 milligrams was used in 2 of the studies, 600 milligrams was used in an additional study. We almost never use mifepristone 600 milligrams anymore. And so 200 milligrams is definitely appropriate and was equivalent compared to those. They use different doses of they use the same dose of misoprostol with different routes of administration and came up with the same results. So it likely doesn't matter what route of misoprostol administration is chosen. So to that end, in previous management of miscarriage studies, they looked at vaginal versus sublingual and found those rates were equivalent. Oral might be a little less equivalent for misoprostol administration. And buccal hasn't really been studied in the medical management of miscarriage literature, but in the Med-AB literature, that's the most common route of administration, has been shown to be equal to vaginal and sublingual administration. The one important thing is that with vaginal administration of misoprostol, you do get fewer side effects. So that might be more desirable for certain patients. Finally, is there a dosage regimen? Can we reduce the misoprostol dose, get the same effect and fewer side effects? There have been a couple studies looking at the 400 micrograms versus 800 micrograms, though 800 micrograms is what's generally used because that's what's been used in medication abortion. It showed equivalent expulsion rates. However, patients that took 400 micrograms did have to redose a day later with a higher frequency, but eventually came up with the same expulsion rates. They did report reduced side effects. In the Mifi-Miso studies, they used a very pragmatic approach to redosing. They would give patients a second dose of misoprostol, and if subjectively they felt like they hadn't passed the pregnancy tissue after 24 hours, they would just redose that medication. In the medication abortion world, we often will redose mifepristone or misoprostol immediately at 4 hours for gestations that are higher than 9 weeks, because there has been shown to be a higher expulsion rate with that second redose at 4 hours in those pregnancies. However, in the medical management of miscarriage literature, they included, all 3 RCTs included patients with gestations up to 13 weeks, and they did not find a difference in the expulsion rate based on gestational age. So I don't think that that is something that's necessarily necessary in medical management of miscarriage. So then when you're following these pregnancies up, How do you tell whether they have been successful? And that's one of the reasons why we have such wide ranges of success rates in medical management of miscarriage, is because some people use 15 millimeters endometrial thickness and other people use gestational sac expulsion. And this has actually been studied. There is no endometrial thickness that predicts success. The absence of gestational sac is the only thing that predicts success of a medically managed miscarriage. So if you don't see a gestational sac, it worked. Endometrial thickness also does not predict retained products of conception. It doesn't predict need for surgical treatment or the presence or duration of bleeding. So what about beta HCG levels? Can they be used to predict complete expulsion? We do not have a ton of data, and we don't have data that will tell us that with the MIFI-MESO regimen. But there was one study from New Zealand that looked at patients that got misoprostol and what their rate of change of beta HCG was 7 days post misoprostol. They found that a decrease in HCG of 87% predicted expulsion of the gestational sac, and a decrease of 94.5% predicted no need for surgery. So this is actually surprising that they could do that a beta HCG would predict surgical outcomes. This is a small study. It needs to be repeated with the regimen that we use now. One of the RCTs did look at beta HCG fall, but they only looked at that day 4 fall. And we've seen from the Med-AB literature that that's just too soon to get a threshold. So this study, unsurprisingly, was better at telling us what that threshold was, because they used a day 7 level. So likely you need a day 7 level to really come to an answer for beta HCGs. Okay, Laura's going to very briefly address this.
Okay, so you can't talk about management of early pregnancy loss without talking about surgical management. Surgical management, as Dr. Bennett said, used to be the only management until people realized that patients may want different things. Initially, everybody would get a sharp curettage. So you were diagnosed based on dubious data with an early pregnancy loss, and then you got a sharp curettage. Data subsequently showed that sharp curettage leads to increased risk, and the World Health Organization and the Society for Family Planning recommends against the use of sharp curettage in early pregnancy loss. And so now, almost everybody uses electric vacuum aspiration, and there's a smaller subset of people that also use manual vacuum aspiration. So we're going to talk a little bit about both of those options. Both MVA and what I'm going to call EVA, 'cause it's easier, generate adequate suction to empty a uterus. An electric suction can use up to about 100 millimeters of mercury, depending on your device of suction, but almost everybody uses like the 50 to 75. I use like 60, but I think a lot of people here use like the 50 range. The point that I'm going to make here is that a manual vacuum aspirator will use 60 millimeters of mercury. So there's kind of a myth that the MVA produces less suction. It produces 60 millimeters of mercury, which is actually higher than what many people here use when they're using the electric suction. There is a difference, though, in the amount of products that both devices will contain. So the canister for the electric aspirator will contain up to 2 liters of products of conception, and the MVA canister holds 60 milliliters before you have to empty and reuse the canister. There's no clear gestational limit for MVA. For electric vacuum aspirator, the cannula will go up to 16, which is about 16 weeks gestation. But most clinicians for an MVA will use it at 9 weeks or less. And that's primarily just because beyond that, you're refilling that canister more than once, which just takes more time. So there's actually numerous studies comparing EVA to MVA, and they're looking at different endpoints. In general, they look at the time of the procedure. They look at patients' perception of pain, patients' satisfaction with the procedure, and then also the likelihood of having a completed procedure at the end. And my favorite study is a randomized controlled trial done by Mark Nichols, who's like big in the family planning world at OHSU, where they randomize patients at an outpatient abortion clinic to either MVA or EVA. And then they looked at patients' perceptions of pain. They did, I don't know if you guys know, there's this pain curve, and more than a 20 millimeter difference on the visual analog pain scale they considered clinically significant. And then they looked at the time between the two procedures. And then they also did a regression analysis based on who did the procedure, the attending, who was only Mark Nichols, or the resident. They had first-year residents that were at the clinic doing the procedure supervised by the attending. And what they found was that no matter who the operator was, the EVA was faster than the MVA by about 1.5 minutes, which is statistically significant, but questionably whether that's clinically significant. Pain scores were the same, no matter who the operator was or what method that they used. And the likelihood of completion was incredibly high and was the same for both procedures. They looked at, there's also a meta-analysis of 10 studies that looked at the differences between EVA and MVA, and they came up with the same thing. Patients were very satisfied with both methods. There was no difference between the two. Pain scores were the same. Speed was faster with the electric suction, but it was sort of a statistically significant, maybe not clinically significant difference. And so ultimately, the thought is, you use whatever makes the most sense for where you are. If you're in the ER and you need to empty a uterus, and then, you're not going to be using the electric suction, and you can confidently say that the MVA is a great tool that is equivalent to use in that setting. Or if you're in your office and a patient wants not going through the hassle or expense of going to the OR, you can confidently say that offering that patient an MVA will give them a good outcome. It's going to complete it. Their pain and their satisfaction are going to be equivalent to whether you did it with electric suction. So in summary,
SRU criteria are accurate, but they are not perfect.
serial HCGs, and this is important, and I didn't much stress it before, really have little utility once a pregnancy is seen on ultrasound. HCG rise less than 33% every 48 hours for 3 or more checks reliably predict non-viable pregnancy.
Mifepristone and misoprostol are the most effective regimen for medical management of early pregnancy loss.
Electric suction and manual suction are equally effective at surgically managing early pregnancy loss.
Expectant medical and surgical management of early pregnancy loss are all safe and effective options, and the clinical context is important, and shared decision-making is paramount. Thank you.
Okay, we're happy to take questions.
2 minutes. 2 minutes.
Yes, Dr. Landry. No, it was not even. It was an ultrasound that demonstrated a gestational sac with a yolk sac or fetal pole. That was where they set it up.
Whereas the SRU data, which is almost all based on this big group out of the UK, viability is based on seeing a viable pregnancy at nuchal at 11 to 14 weeks, which isn't 100% viable, but like most of them are.
Not know. I can speculate,
Because there are, yes.
but I don't know. That's the point of transfer
I'm
to
sorry.
the generalist division. I don't know.
They were out of the unit by then.
I have a question for you with regard to, you get the call from the ED, someone has retained products of conception, whether it was early pregnancy loss or, an abortion back in the day. So one rule of thumb that I was sort of taught was like 2 centimeter endometrial thickness was kind of predictive of probably needing to go for a DNC. Do either of you have any kind of rule of thumb that you use clinically, not tested in the literature, but that you use for needing to take somebody back? Obviously, if they're hemodynamically unstable, you go, but
right. So
otherwise.
The volume of bleeding is really the thing, and the persistence of bleeding is the thing that determines whether you need a suction. There is not an endometrial thickness that we can use. So a lot of studies did use to have like a high threshold, 3 centimeters as the endometrial thickness, but even that has not been, in studies, it didn't show that it necessarily conferred a higher risk of complications.
Which you can imagine, because blood
Yeah.
clot products, decidua, it's really hard on ultrasound to get reliably useful information. But if you see a gestational sac, That's different. That's retained products. So it's really shared decision-making with the patient, the persistence of bleeding and how symptomatic they are. If they're in the ER, they're probably symptomatic. So you could consider management.
Have there been any studies comparing the cost of EVA versus MVA?
Yes, the cost is lower with MVA. That's a very good point. Yes.
Also more environmentally sound. It uses much less garbage.
If you're reusing the same MVA, there are fully disposable kits that have even plastic dilators, which maybe are less environmental.
But even that, if you look at what we throw away in the OR.
Yes, that's true.
This is a loaded question, but as usual, in the post-Dobbs world, is there any legal implications to what you presented today in terms of following this data? Expectations, how many betas, et cetera?
Yes, there are legal implications. However, most of these patients are going to meet a very close threshold for, I mean, they're going to be close to 99% for having a non-viable pregnancy, even if they would want to act sooner than, sort of the SRU criteria. And so the level of risk is likely small, but we're operating in a real no man's land here in terms of known risk and unknown risk.
We had that debate, Eliza and I, numerous times over this. We're like, but look at this case report that showed this patient that had like declining betas and nothing on ultrasound and had a viable pregnancy. Like those things exist, but no test is perfect and you have to operate with the best clinical data that you have. And this is the best data that we have, but it does point out the problem with the law. It is not a law that fits with the evidence that we have, and it's not a law that makes any sense in the way that we clinically manage patients.
And we have championed for years shared decision making and patient autonomy, and we shouldn't give up on that. Patients you should still tell them that, if they have a 99% chance of having a non-viable pregnancy, they deserve to have that information.
And then they can decide, I want to wait this out until the very last minute to make sure that this is viable. And if they want to repeat ultrasound, Eliza and always do. If somebody has a diagnostic non-viable on ultrasound, they get to the OR and they're like, I just want to see one more time. You just do it because then that patient feels more comfortable and that is their decision. Conversely, there are people, many in the REI field too, that want a more expeditious diagnosis. And then you offer that because there's a very good body of literature that supports that based on the criteria we presented, the pregnancy is not viable. Thank you.
Thanks.